Hi everyone, so we are going to do the next portion of chapter 16 lecture attached to the PowerPoint that you guys have access to on Blackboard. So yesterday we left off starting into cytotoxic drugs and how the cytotoxic drugs work and affect the cancer cells or the tumors specifically. So with cytotoxic drugs, and particularly the alkylating agents, they work by binding and damaging the DNA during the cell division process. So when you think about cancer cells, and they are essentially our own cells that have gone rogue, it's during this DNA change or a multiple division process of when they are normal healthy cells going into the rogue cells, that's when these particular agents go on the defensive and actually attack the cells during that time, and hopefully have a better chance of preventing the cancer cells from being able to multiply and spread essentially throughout the body. Special handling requirements with the alkylating agents is both for personal protection during preparing and then personal protection for those that would actually be administering the drugs. Including, and some people don't really think about this, it's not just the handling of the medication specifically. So if you're working in a facility that is preparing these medications, and let's say that you pass that off to a nursing staff and the nurse is giving these medications to the patient, it also includes once the patient has taken it and their waste. So their fecal waste and their urine waste is something that has to be handled with caution as well, because we know when we take medications, and chemos are not separated from this. When you take medications, it goes through the process of absorption, distribution, metabolism within your body, and then finally excretion. So a lot of these medications, including the chemotherapies, will have some sort or portion of the chemo drug that is being eliminated in the urine. So if the patient is in the hospital and they're using a bedside pan, or they are catheterized or anything like that, the nursing staff still has to handle that urine with care because of the potential of exposure from whatever's being excreted out through the body. Anti-metabolites work, either they interfere with the enzyme production or the activity needed for DNA or RNA synthesis, or they act as a false nucleotide, becoming falsely incorporated into the DNA. So it's basically tricking the cell that it's not, or that it has already mutated, when in fact it has not. So it's kind of a little magic show, if you will, with that. Special handling and requirements are the same, both in administration and how the patient is taking it, any caregivers that are giving it, and including nursing staff. One example of an antimetabolite drug is methotrexate, and methotrexate is actually very toxic. So one thing that they tell us as pharmacy technicians is kind of be aware of specific dosages. So in the case of methotrexate, the recommended is that methotrexate is actually never dosed on a daily basis for extended periods of time. So daily orders tend to vary between 2.5 milligrams every day and even lower, but not for extended periods of time. So if you have a prescription written for methotrexate that says 60-day supply, that's something that you should definitely alert your pharmacist. Now, does that happen? Yes, there's certain cases, certain patients, depending on what they're treating, that is protocol for that, but in the most cases it is not, and should be something that is brought to the pharmacist's attention. The topoisomerase inhibitors, again, that's a mouthful. They interfere with DNA repair function and disrupt cell replication process. So when the cancer cells are being destroyed by the chemotherapy, it doesn't allow the DNA of those cancer cells to be able to repair itself. And it also helps to prevent, these little crane flies are driving me crazy. It also helps to prevent those particular cells from continuing to replicate. High doses of certain drugs are with these inhibitors more specifically, do cause for the physicians to kind of evaluate how that route is going to be given. There are some oral or PO versions of chemotherapies, and a good majority of them are actually administered intravenously. Sometimes those are done through central venous catheters, just depending on placement. So with the level of toxicity and how harsh some of these chemos are on the body depends on how they're going to be administered to our patients. Antimicrotubule agents, so things like palcitaxel, which is Taxol, vincristine. These are some common ones that I saw in the hospital, although I wasn't able to prepare them because I worked in New Mexico. And in New Mexico, pharmacy technicians cannot compound chemotherapies, but I did a lot of watching and observing our pharmacists, and these were some very common chemos that we saw come through. They interfere with the formation and the function of the microtubules, which ultimately prevents the cell growth and function. So as these cells are continuing to replicate, when we add in these particular types of cytotoxic drugs, it's preventing their growth and also helping to prevent them from being able to function in a way that allows them to continue to replicate. Vincristine and vinblastine must never be administered by intrathecal route. This warning is crucial. Fatalities have been reported around the world when vincristine was inadvertently administered as an intrathecal agent. So that's something, again, that we have to be very careful of and what we need to watch out for. If you happen to see an order come through for vincristine and it's written for an intrathecal route, that is your warning right there. No, you need to bring it to the pharmacist's attention. It's kind of common knowledge now between, oncology physicians and pharmacists. So usually that's caught early on. But in the event that you do see a prescription like that come through, you just want to make sure that you bring that to the pharmacist's attention. So there are a class of miscellaneous cytotoxic drugs. Bleomycin works by causing cuts or breaks in the DNA strands, which prevents the cell proliferation. Asparaginase breaks down the asparagine, which is an amino acid required by leukemia cells and which they are not able to make on their own. So we have asparagine in our system, and so we will take this drug to help break down what is in our system as an amino acid, which does not allow the leukemia to have access to it. Since the leukemia cells don't produce it on its own, it's relying on our body's store of this amino acid, and that's how it continues to spread and infect the body. If we block that out, then they don't have the ability to use that amino acid. So hormonal therapies. So some tumors depend or are dependent on hormones for growth. We've talked about this in length, not only in our endocrine system, but again here, when you have patients that are on any type of hormone replacement therapy, in particular females who are either of menopausal age or they've had a hysterectomy or some sort of that, and we're using hormone replacement therapy to deal with some of the symptoms that they're suffering from a lack of or a complete absence of these hormones, hot flashes, night sweats, irritability, those type of things. But One thing that we also have to be very aware of is that as patients age and we are adding in these additional hormones, there's some opportunistic cancers that will thrive off of that and thrive off of the extra hormones, estrogens, and that type of stuff that are being presented, and in particular breast cancers. Hormonal or endocrine drug therapies target the hormonal agent which is contributing to the tumor growth. So some females, we're just going to take a example with breast cancer. So if we have a patient that has been diagnosed with breast cancer and it is the type that is estrogen fueled, there's many different options that the patient can do depending on the severity of the cancer. Chemotherapy, they can do a double mastectomy, which is removal of both breast and breast tissues. They can do radiation therapy, and then if the female decides to keep both of her breasts, one thing that they can do is, once she has gone into remission and they have treated the cancer, they can put her on medications that block her body's production of these hormones. So if her breast cancer is estrogen fueled and then she goes through chemo and they're able to, get her to a cured cancer, then physicians will work to prescribe anti-estrogen medications that will block her body from being able to produce the estrogen. Therefore, it's not going to continue to fuel or restart that whole process all over again. Anti-estrogen, so how they work. Tamoxifen is the go-to. It blocks the estrogen receptor. Anastrozole, letrozole, they prevent the synthesis of estrogen in the body. And these particular ones work only in women who have experienced menopause. So their role in therapy is the treatment or prevention of breast cancer, depending on the drug specifically and the dose. Side effects kind of cause the same thing as what a female patient would suffer if they were, or experience if they were going through menopause. So hot flashes, mood swings, depression, an increased risk for blood clots, and an also increased risk for endometrial cancer. Anti-androgens, so they work by blocking the activity of testosterone at the receptor level or interfere with the production of testosterone. So if we have male patients, right, there are certain types of cancers. Breast cancer is typically specific to female, although there are cases of men having breast cancer. But for men in particularly, their hormone-fueled cancer is typically prostate cancer. And a lot of times that is related to directly related to the amount of testosterone that their body is producing. So side effects of anti-androgens include a decrease in libido. They can also experience hot flashes, breast tenderness, interestingly enough, gynecomastia, which is actually the development of breast tissue. Cautions and considerations. It's important for patient education regarding potential for drug interactions. So again, anytime your DURs are popping up and there's a drug contraindication or a drug food or a drug supplement, any of that needs to be brought to the pharmacist's attention immediately. That is also why it's extremely important for us to get as much information from our patients that we can when they come in, especially if they're new patients. What are your allergies? Are you taking any over-the-counter medications? Are you taking any dietary supplements? All of this can give your pharmacist the full picture of what a daily routine as far as what they're taking and putting into their body is, and how that's going to affect any prescriptions that they are prescribed. LHRH antagonists, so they initially stimulate production of the sex hormones, then they shut down the production through a negative loop feedback. So basically that is eliminating the sources of estrogen, progesterone, and testosterone production. So it's kind of another little trickery move that they're doing here, but ultimately it's shutting down the production or the sources of those three particular hormones. And again, that's used typically in prostate and breast cancer. So targeted anti-cancer therapies. So these are directed at specific molecular entities required for tumor cell development, proliferation, and growth. And it is considered the future of anti-cancer treatment. So the advantage of this is that it's exerting fewer effects on normal cells. So early chemotherapy medications were brought out, and again, these things were developed from weapons of war. So again, think on that level of how toxic these medications are. Early on, we were looking for, okay, we need something to treat this. We need, to figure out a way how to cure these cancers. And early chemotherapy treatments, and even some through still used today, they are not target specific. So that's why we have such terrible side effects sometimes with the nausea and vomiting and alopecia and all of those things. The chemotherapy is targeting all cells, not just the cancer cells. Certain chemotherapies do not have the ability to differentiate between what is the bad target and what should be left alone, because those are healthy cells. In this new targeted therapies, this is the future of what we're seeing is they're developing drugs that are able to specifically identify these cancer cells and target them specifically and leave our normal healthy cells alone. And these actually tend to be better tolerated than the cytotoxic drugs. And again, that's because it's not causing as much extensive damage as the other chemotherapies are. The other chemotherapies are doing their job, and at some point in history was the only thing we had to work with. But as research and everything has come forward and technology has grown, we're starting to get more and more of these specific targeted anti-cancer therapies that are targeting the tumors specifically. They are targeting the rogue cancer cells specifically, and giving our body kind of a head start and keeping all of our healthy cells, which helps our immune system and all of that stay healthy. Angiogenesis inhibitors, they work by preventing tumor cells from building blood vessels that will supply the tumor with vital nutrients. So the tumor's a growth. It needs blood supply, right? It needs that oxygen. It needs that blood supply to be able to continue to grow. These particular inhibitors cut that off. They don't allow these tumor cells to build their own blood vessel sites and allow them to use our blood in our system to be able to fuel them. Different examples there, okay, and they can use these different ones in certain therapies. So Avastin is used for breast, lung, colon, and brain cancers. The Revlimid is used for blood cancers, and then a combination of two there are used for multiple myeloma. Monoclonal antibodies, so they're directed against specific marker or antigens on a targeted cell. So some of these antibodies here do have limited range of activity since it's designed to target specific tumor markers. So again, this is a specific targeted therapy, but it's very limited range. They have different types there. If you're going in and looking at your PowerPoint, one is specific to particular cells found in breast cancer. There's another one that is specific to the lymphocytes that are present in non-Hodgkin's lymphoma, and then one that's a combination drug that affects the epidermal growth factor receptors of the cancer cells in different various types of cancers. Allergic reactions are definitely something that is very common across all types of chemotherapy medications. And again, it's your body's not recognizing it. A lot of times the physicians will order for doses of Benadryl to be given at the same time or shortly after chemotherapy has been administered, and that's to help the body not reject or have those allergy effects once the drug has been administered. Signal transduction inhibitors. They work because they are developed to target tumor cell receptors. They block or prevent the communication and intracellular functions related to tumor growth and proliferation. And again, they use these in specific types of cancer, and then a combination drug they use specific for a specific type of leukemia. So, investigational therapies. Okay, so this kind of ties into not only what you've learned in law, but also ties into kind of what we're covering in chemistry from that aspect. So remember that investigational drugs, these are medications that have not been approved by the FDA, but they are being studied as part of a clinical trial or a clinical research program. These programs are necessary, right? This is where it's kind of the last phase of a new drug getting approved and being brought to the market. They have, the various sizes of the clinical trials are different, and each patient is required to sign an informed consent. Remember that the informed consent is a sheet of information or multiple pages of information that is written in layman's terms for our patients that don't have any medical background, any medical terminology background, for them to understand what the entire study is, what the drug that they will be taking is, and what the risks of that are. Since this is a human clinical trial, they have to understand that there's no guarantee that it is not something that would cause a fatality, but that's the risk that they're taking. Most of these patients are kind of in a situation where they don't have any other options, right? So expanded access drugs. So the use of particular investigational agents for a specific disease outside of a clinical trial. This approval is granted on a case-by-case basis and only in treatments of a serious medical illness or life-threatening condition. So one of the things that is kind of being brought to legislation right now is, the patient's right to choose. They have the right to, something that they're trying to get past is, patients that are in end-of-life care for certain types of cancers or stuff like that, that they have access to be able to participate or get their hands on these investigational drugs, regardless of what the risks are and regardless that the FDA has not approved that yet. So handling and administration of chemotherapy agents. Okay, so let's say you had an accidental exposure through inhalation. So potential exposures through inhalation include opening or breaking or crushing the tablets or capsules, preparing hazardous drugs without adequate respiratory protection, ingestion, eating or drinking in areas where hazardous drugs are stored or prepared. That is why we have such stringent standards and rules set by USP, the United States Pharmacopoeia. Remember, USP sets standards for sterile compounding, which is 797. They set standards for non-sterile compounding, which is 795, and then they actually have standards set that are continuing to grow every few months on sterile products or hazardous products, and that is USP 800. One of those things is using common sense. If you're working in a hospital, pharmacy, or any type of clinic that does IV therapy or chemotherapy using their clean rooms, you're not going to be eating and drinking in those rooms, period. Not only is it a risk to contamination for our patients, but in this case, think about the level of toxicity of these drugs. If you accidentally ingest something that happen to have some powder fall into it, it's dangerous for you as well. Placing food on contaminated surfaces, touching food or mouth with contaminated hands. Injection, a needle stick injury occurring during the preparation or administration. So I am clumsy. I had many needle sticks on my own, while I was preparing sterile products in the IV room. And these were drugs like potassium chloride and things like that. Although it still poses a risk, it's not as dangerous as your exposure to these hazardous drugs. It's imperative that you let someone know right away that you've had a needle stick injury. This was the drug that you're using. They're going to refer directly to the SDS and see what type of care do you need to go to the emergency room. Is it monitored? Do you have to have blood draws? All of those things to see how they're going to treat the exposure. Topical absorption, handling chemotherapies without wearing PPE. You're hearing PPE all over the news right now, right? Personal protective equipment. We covered PPE when we were doing our sterile products course. So PPE plays a different role in different settings. With what's going on right now in the coronavirus and all of the hospitals out there, their PPE is to protect our nurses and doctors and respiratory therapists and everyone that's on the front line caring for our patients. In a pharmacy setting, inside of the pharmacy in a hospital, that PPE is not only protecting them right now. I know some of the hospitals have required all staff to be wearing PPE during their whole entire shift, regardless if they're in the pharmacy or not. But we are protecting our patients. You're not going to waltz into an IV room with your hair exposed, you haven't washed your hands, you have no booties on your shoes, gowns, gloves, anything like that. Not only is that protecting our patients and ensuring that we're contributing and ensuring a sterile environment for these particular medications, but we're also protecting ourselves. So personal protective equipment, again, protects the handler from being exposed to the hazardous drug or their residue, and protects the product by keeping contaminants away from the medication. So components of PPE from a pharmacy aspect: shoe covers, a disposable gown that is impermeable to fluid, which means it doesn't absorb the fluid, sterile chemotherapy gloves, which are different than our regular drugs that we use, our gloves, not drugs. Chemotherapy safety glasses, yes, you must have safety glasses on, or face shields, okay. A hair cover, and then a disposable respirator, so N95 mask, those type of things. The N95 masks are specific because there is a filtration process inside of the mask. So as you inhale, there's a filter that's catching all of that, whether it's a bacteria, virus, a chemotherapy, particulates that are in the air. Those are what those masks are designed to do. Last piece, we're going to talk here about the spill kits. So if you have a chemotherapy spill, you just don't waltz out and grab some, paper towels and clean it up. There's actually a specific process and a specific kit that is needed to be used. And these are called spill kits. They are used to clean up small spills. They are available in all areas where hazardous drugs are prepared, administered, or transported. The used supplies are to be placed in a sealed plastic bag and disposed of appropriately. So you've probably seen in the classroom, we've had yellow sharps containers essentially, and the red ones are biohazard waste. We throw our needles and any blood byproducts and stuff in there. But the yellow ones are specifically for hazardous drugs. These things include our chemotherapy medications. Large spills are to be cleaned up by a hazardous team or a hazmat team specifically. So let's say that you're preparing a chemotherapy and you accidentally drop the vial of the chemo inside of the IV room or the chemo room. And that's typically a small enough spill that you can go ahead and use a spill kit to clean that up. If you find you have a spill that your spill kit is not big enough or doesn't contain enough components to clean appropriately, that's when the hazmat team needs to be called. You should also let your supervisor know right away, alert your pharmacist, because they may make that decision for you. Even if you think that you can clean it with a spill kit, they may, squash that and decide to have the hazmat team come in. Safety data sheets, these should be used to guide the cleanup process after an accidental spill. The SDS is specific. It identifies the drug, the potential hazards, handling and storage requirements, and then the first aid measures for accidental exposure. So an SDS is designed not just specifically for chemotherapies, but these SDS are designed for any type of hazardous material we are going to come in contact with within the facility that we work in. In a pharmacy, especially in a hospital pharmacy, you can probably imagine that these SDSs are pretty large. Sometimes they're actually multiple binders, and that's just because of the quantity and the amount of different types of hazardous drugs that we carry. We also have to list our bleach in there. We have to list our alcohol, anything, even our cleaning supplies, those type of things that, if the technician is cleaning up something and they accidentally squirt, isopropyl alcohol in their eye, what needs to be done. A copy of each drug's SDS is to be kept on file or have an established internet link in the workplace. So some facilities, depending on how large they are, have gone electronic, and they have their SDS online, just because it's, instead of having 12 binders full of information, they do it all online. But typically each department is responsible for updating their own SDS, because what we store and what we have in pharmacy is going to be completely different than what you're going to find in sterile processing and the cafeteria and different areas like that. We're going to go ahead and pause there. If you have any questions, be sure to email me right away. You guys have done a good job. Some of you are not participating in both discussion boards. I haven't had anyone send me an email yet to let me know if they like the videos or not, so I hope you're seeing these all the way through. These are important. This is lecture. This is me being able to kind of go in depth with the PowerPoint. So let me know how things are going. For the most part, everyone's doing really well. I know, again, this has been a tough transition. It's temporary. We're going to be back in the class again soon, hopefully. And, I'm here to help you get through. So email me right away if you have any questions, and just email me with some feedback. I would appreciate it, and I'll see you all later.